very well because I'm in my colleague and now boss's John Joseph's office, and I'm not big enough to fit on the screen, but I'm going to try. And I'm going to talk, as the title says, not only about intravesical therapy, but treatment of low and intermediate risk bladder cancer. Um, and the first thing I'm going to discuss is really the classification of this disease. Low risk tumors, this is from the European Urologic Association, EUA. Low risk tumors are newly diagnosed tumors less than 3 centimeters in size that are high grade, that are low grade and that are confined to the epithelium, TA tumors. High risk tumors, according to the EUA, are any tumor that's high grade, any tumor that's T1, CIS, aberrant histology, and then multiple recurrent, very large, low-grade tumors. But realistically, they're higher-grade tumors. Intermediate tumors are anything in between. So if you had 2 1-centimeter tumors at the first time of diagnosis in the bladder, that would be low intermediate risk. It's not low risk. If you had a tumor 3 years after your original TURBT, that's also low intermediate risk because it's not newly diagnosed. The American system is a little bit different, and I actually don't like it quite as much. The low risk tumors are the same. High risk tumors are similar, but they include high grade TA tumors that are 3 centimeters or smaller as being intermediate risk. They also include T1 tumors as being intermediate risk as long as they're not high grade. And I think both of those should really be considered high risk also. So I like the European system better. And what the EAU did was that they gave points to the characteristics of tumors. And if you added up all the points that the tumor presentation had, you could then get a pretty good likelihood of what was the chance of it recurring or progressing. So for instance, the things you all know about, a grade 3 tumor or CIS, had a modest increased incidence of recurrence, but had a very high likelihood of progressing. On the other hand, million tumors in the bladder was much, as long as they're low grade TA, much more likely to cause recurrences than they were progression. So with this point system, you actually had a likelihood score of what would happen over time. And I think the most important thing to capture from here is that the lowest of all low-risk tumors, score of 0, still had a 1/3 chance of recurring in 5 years. This tumor recurs very frequently. Anything else, of course, recurs more. And this is just shown graphically that the lowest of low-risk tumors, really a third of them, or almost a third, are recurring within 5 years. The more aggressive tumors or the more multiple tumors or the larger tumors recur more frequently. And these primarily come from EORTC, that's the European Cooperative Group, from their placebo arms of their studies, so that you know that you have pretty good data on how they reach this. This is the risk of progression, and in reality, we're only going to talk about this very low risk group or this group. We're not going to talk about the high-grade TA tumors or high-grade T1 tumors that obviously can progress frequently. The kinds of intravesical agents available can be categorized in different ways based on their mode of action. The alkylating agents, mitomycin is the one you know about most, but also Thiotepa, which very few of us use anymore. Epidural, which is not allowed in this country. Cause DNA cross-links, both inside a strand of DNA and between strands. And this results in degradation of the DNA, so the cell eventually dies. Anthracycline antibiotics, the upacins, epirubicin, doxorubicin, pirarubicin, valrubicin, every rubicin and pure rubicin are not available in this country either right now. They work by binding to DNA base pairs, and the result is that transcription can't occur. So proteins can't be made out of them, so those cells are going to die. Microtubule inhibitors, taxanes, obviously affect mitosis and prevent mitosis from going on. And we'll talk about gemcitabine's mode of action, but it's incorporated to the DNA of dividing cells, and the strands can't be reproduced. We'll talk about that more. Cisplatin, and this only comes from one paper, but it's just not used at all, and I'm not sure it's because of this paper, had a 10% chance of anaphylaxis. It's pretty awful for low intermediate risk disease. Mitoxantrone, which is another form of chemotherapy that has been used for prostate cancer, causes a chemical cystitis and people are miserable. So this is the spectrum of drugs that we have primarily. And basically, BCG is better than anything, but only minimally so. For the intermediate risk tumors, mitomycin is almost as good, epi is almost as good, doxorubicin, or adriamycin isn't quite as good. If you compare them, epirubicin is better than interferon or adriamycin. BCG is better than anything, and if you use maintenance BCG, any maintenance program you want, it could be the SWOG, every 6 months, give 3 weekly installations, or it could be 1 installation a month, which is what's done in Europe. BCG was better than mitomycin, but if you didn't give maintenance BCG, it's not for intermediate risk disease. This is a forest plot here showing that mitomycin is better if you don't give maintenance, and BCG is better if you do. And these were a variety of studies that showed that as well. BCG without maintenance did worse than BCG, than mitomycin without maintenance. And with maintenance, BCG clearly did better. This is time to next recurrence. This is just another study that was included in the meta-analyses. And again, BCG with maintenance is better than mitomycin. Not much to argue about. BCG is more toxic, however. It irritative voiding, fever, joint pain, of course it causes arthralgias, things like that, more common in BCG patients. And I think all of you know that in terms of seeing how patients respond. I throw this up because we'll talk about it later, but any given study can show one drug is better than another. This was intermediate risk, GEM versus mitomycin, and everyone got monthly maintenance of their drug if they were effective. And you can see the gemcitabine is better here. There are studies to say mitomycin is better as well, so this is not a study available, but they're probably about comparable in efficacy. GEM is much less toxic, however. That virtually any set of symptoms you want, mitomycin is much more unpleasant to get. And you can see the percentages here. I don't know. Can you see the p-values, or is Tony Benjamin's picture of blocking the screen? I can't really tell, but I can't see this final column.
You can just move it. There you go.
There we go, Tony. I'm sorry. Hi. But you can see that clearly mitomycin was significantly more toxic than gemcitabine.
You just have to click on it again to move that.
Click on it again.
Then not go down.
There you go. There we go. So the summary is that BCG plus maintenance for intermediate risk bladder cancer is better than anything. But if it's BCG induction alone, it's not that much better than anything. Mitomycin is probably similar to epirubicin, which we can't get, in gemcitabine, which we can get in terms of efficacy, and they're all better than adriamycin or Thiotepa. Whether an immediate post-TURBT installation improves efficacy is questionable, and I'll show you some data on that in a minute as well. There are all ways to improve mitomycin. Again, one is not available in the United States. It's called microwave or electromotive mitomycin, which allows quicker penetration of mitomycin into a tumor. This is supposedly shown graphically. And this shows time to recurrence. And compared to electromotive mitomycin with BCG, this is a cumulative incident plot. So the higher number is worse off. They're occurring more commonly. So BCG occurred more commonly than electromotive mitomycin. And then when the people actually got, this was the intent to treat study, meaning that some people didn't get their treatment, but they're included here depending upon how they were randomized. If they only included people who got the treatment they were supposed to get, there was a significant reduction of recurrences by the electromotive mitomycin. It's also more toxic, though, than even BCG. Pain during session, pain, vomiting, things like that, where people with low and intermediate risk disease don't really need to go through this. And so, even though it's effective, it had side effects, and that's why the FDA didn't approve it for the United States. Jessie Au, who was a pharmacist, pharm PhD at Ohio State, came up with this, and what she did was try to improve the efficacy of mitomycin. So she increased the concentration of it by dehydrating people the night before so they're not producing a lot of urine, diluting out the mitomycin. She increased the concentration by putting it in half the amount of the dilute that we usually use. We usually put 40 milligrams and 40 cc's of saline. This was half of that. And then she alkalinized the urine because mitomycin is more stable than alkaline urine. And in doing that, again, it was more effective. Let me go back. It was more effective. Again, this is the intent to treat. And this is the group that was actually treated and optimized mitomycin was more effective in preventing recurrences than standard mitomycin was.
Dr. Matthews, could you be a little louder? It's a little hard to hear you, I guess.
Are people having trouble hearing me?
No, I hear you fine.
Okay,
There you go.
there we go. Okay. There's optimized mitomycin was minimally more symptomatic than standard mitomycin. There was some dysuria and cystitis, only this reached statistical significance. I don't think the infections mean much. But in general, the symptom complex was symptom and toxicity of the two treatments were pretty similar. And they were usually not that severe. So if you want to and you have the time, you can try to, when you have a patient who needs mitomycin for intermediate risk disease, you can try to use optimized mitomycin. I sometimes do it, I don't do it as religiously as I should. So we're going to talk for a few minutes now about immediate post-TURBT intravesical therapy. And how this works is theoretically it prevents implantation of circulating tumor cells perturbed by the TUR inside the bladder. And there's a lot of, these are all animal studies, and they come from 20, 25 years ago or longer, which indicate that this, in animal models, you can prove that this is occurring. It would be very hard to prove in a patient, but it makes sense that that's what's happening. The other thing is that you all know this from enhanced cystoscopy, that there are areas of tumor in the bladder that you just don't see very well. Only when you use blue light or narrowband imaging can you see them. And clearly, immediate post-TUR intravesical therapy can kill those as well. So the background to use immediate post-TURBT intravesical therapy is that, of the 80,000 cases of bladder cancer each year, about 45,000 are low grade, non-muscle invading tumors, low and low intermediate risk. They recur frequently. We already showed that. It's recommended, although it's not as strong a recommendation as it will be the next time the AUA comes out with its bladder cancer guidelines, where I'm sure it will receive much stronger recommendation. But it's recommended by the Europeans and the AUA. Despite that, it's rarely used in this country, and we'll see later on how rarely used it is. But this is a meta-analysis done by the Canadians, which were from 7, 8 years ago, and all the studies, almost all of them fall on this line. We'll talk about this one by Foley a little later, but all the studies are falling to the left of the line that immediate post-instillation is better. And here's another one done by the EORTC. And again, mitomycin, epirubicin, pirarubicin are all better. Only thiotepa wasn't. So they're all better in terms of preventing recurrences. There's about, if you add this up, at 5 years, we should be here, there's about a 12% absolute reduction in tumor recurrences with the instillation therapy. There's some toxicity. This is particularly, again, with mitomycin, dysuria, urinary frequency and urgency, and occasionally some very serious toxicities if you give it to someone in which there was bladder perforation can occur. So they're not completely innocuous agents, but particularly mitomycin. So for several reasons, we decided to do a study in SWOG. This was published a little less than 2 years ago in JAMA, looking at immediate post-op gemcitabine. That we use gemcitabine because it is useful, as you all know, in metastatic or locally advanced bladder cancer, both alone and in combinations, neoadjuvant and adjuvant treatments. It's a pyrimidine analog. So what that means is difluorodeoxycytidine, and it competes with cytidine for incorporation into DNA, but it has to be taken up by the cell, not excreted by the cell, not inactivated, which is usually deaminating uridine, and then it has to be phosphorylated. 3 phosphates have to be put on to add to DNA, so it takes time for it to work. That time is usually about an hour, hour and 10 minutes to get optimal incorporation into dividing DNA. But it competes with cytosine, and it doesn't win all the time, but it wins enough. And once that happens, one nucleotide can be added on, can be added on, and then after that, you don't have the machinery to edit it out or to continue DNA synthesis along the strand or copy. So that strand can't be duplicated at all. So that cell's dead. You know about all this other stuff that I just showed, one of the studies where it holds its own against other more standard intravesical therapies. So we took people who were suspected of having low-grade bladder cancer to show how clever we were about that in the study. And they were randomized to receive gemcitabine or saline. There were 2 different stratifications, whether you had more than one tumor or one tumor. 2/3 of the patients only had a solitary tumor, and 2/3 of the patients had newly diagnosed tumors, but these didn't really affect outcome at all. And we followed them for 4 years. 406 patients were eligible to be part of that study. About 85 or 83% of them actually had the TUR and got the installation of drug or saline. And that's actually pretty good. It's probably about 75% is what you expect because you're chicken to give it if you thin out the bladder or there's too much bleeding and you don't want to grab a catheter. But of those 85%, only about 63% of those actually had low-grade disease. Most of the others had high-grade disease. These patients probably had previous tumors, but they papillary histology, that papillary hyperplasia and things like that are in cancer. And some had T2 disease, which is an embarrassment because it's one of them came from Rochester and had T2 disease. Should be able to tell that. In any case, they were included. So we only got down to about 65% of the 85% who actually had the appropriate low-grade histology. But GEM was very, very safe. You couldn't tell the difference between getting gemcitabine and SAFE. It was basically the side effects of the TURB. The grade 3s were really very minor, and they were rare and actually more common with saline. Somehow I checked out. Is there a reason for that? We're trying, I promise you, if you can hear me. Can you hear me at all?
Ed, this is Badar. Yes, we can hear you. Just can't see your face, but we can see your slides and.
They can't hear you.
No. Sure. Did it just go off like that?
Yeah.
Yeah, we can hear you.
I can hear you.
Literally, and this has never happened to us.
Want to tell them,
Yeah, no, I'm gonna text them right now.
and then I have a computer here.
I don't understand. We don't understand. Oh, you can hear us. Dr. Joseph said you can hear it. Can you see? And they see your slides. So Dr. Joseph, just so you know, we can't see anything here.
So you can see my slides?
Yes.
All right, well,
We can see your slides and we can hear your audio perfectly.
Okay, sorry.
Okay, continue on.
It's just a problem with our signal right now. And we can't see what's going on our screen.
If you are able to view your own slides, I think the audio and visual is good, so you could go ahead, but if you have trouble seeing your own slides, then
I'm trying. Yeah, go ahead.
Dr. Patel, can you read?
Everybody, yeah, Dr. Joseph's watching. He said you can see.
All right, so you can see me and you can see my slides, is that correct?
Yes.
All right. So I have papers here, so I know what slide I'm on. So we talked about adverse effect, but I can switch slides too. So is the slide you have now adverse effects and that the two drugs was equally safe?
I'd say just go with that one and then
Okay,
I'll let you
so
know.
if you go back to the adverse effect one, because I can't do it, and the two drugs are equally safe, I'm going to switch to the next slide, which should be the results. And you see that?
Just have audio.
it looks like we've lost
Primary
the
endpoint,
video.
three patient populations. So if you can see that, gemcitabine, that caused a relative reduction in recurrences if you took all patients, those with muscle invading disease and those with no tumor and those with high-grade disease. And if you only took the group at the bottom, those who received treatment, those who had low-grade disease who received treatment, it reduced the chances of recurrence by almost 50%. and it reduced an absolute reduction of 20%.
Dr. Messing?
34% recovery.
I think we're having some
Or
issues
just-
with the slide presentation.
Somebody just said that they can't see your slides right now. So
Yeah.
we're, trying right now to get his
What I would suggest is,
slides back up. You can just keep talking and then,
well, I would suggest logging out one
Try to show
time
you the two
and logging
curves.
back in,
See them?
and that may solve your issue. So why don't you try to log out once, log in, and then re-upload the slides, okay?
Cytidine, was far more effective than saline, both for, the entire group, and particularly for the group that had only low-grade disease and received study treatment. If you had, this would be the next slide, if you can see it, if you had high-grade disease, the single installation didn't make much of a difference, and that was because everyone received BCG in addition. So the chances of recurrence were pretty similar when he got to GEM or not. One of the endpoints was looking towards who developed muscle invading disease. And the thing to remember here on the next slide is that about 4%, 3.5% to 4% of people with low-grade cancers only will go on to develop muscle invading disease over the next 4.
Hi, Ed, can you hear me? Or Sherry? Hello, Ed? I think we're losing connection. Give them a call and start again.
It probably kills tumors that you can't really see, that are visible on enhanced cystoscopy. So it probably works both ways. Next slide. Okay. And half the patient, over half the patients with newly diagnosed bladder cancer, so about 45,000 each year, will have low-grade disease. These tumors recur frequently. Immediate post-TURBT intravesical therapy is effective. There's a lot of evidence to say that. It's generally recommended, although only a weak recommendation, and it's not used. Let me see if I can move this myself. No, I can't. Next slide. These are some meta-analyses just demonstrating that immediate post-intravesical therapy is more effective. They're on the left side, indicating that it has favors chemotherapy. Next slide. This is one from the EORTC, and both epirubicin, pirarubicin, and mitomycin are more effective. Only Farotipa was not more effective than placebo. Next slide. There's about a 12% at 5 years, about a 12% reduction in tumor recurrence. This is a cumulative incidence curve. Next slide. It can be toxic, mitomycin particularly, and here are some side effects. Can you see me pointing, or is that, no, you can't see me pointing. Okay. But in any case, irritative voiding symptoms are the major ones with mitomycin, unless the bladder is perforated, at which point it's much more serious. You can have a lot of dystrophic calcifications, and outside you can have a lot of scarring as well. Next slide. So we did this study through SWOG, published a little less than 2 years ago. Next slide. We use gemcitabine because it's incorporated into DNA competing with cytosine. And once it's incorporated, one more nucleotide can be added, and no more nucleotides can. Humans, primates lack the machinery to get rid of it or to elongate the chain. So cell division has to stop, or DNA synthesis has to stop. It's obviously used in systemic therapy, both in an adjuvant and neoadjuvant way for locally advanced disease and for metastatic disease. And it's held its own against other agents for intravesical therapy, courses of 6 intravesical installations. Next slide. This was the schema from the SWOG study. People got either 2 grams of gem or saline, and then they were followed. Next slide. That about 85% of those who were eligible actually received the TUR and intravesical therapy, but only about 63 or 64% of those actually had low-grade disease. The rest had other histologies. You can see them there. Next slide. I think this is the one we left off on, that it was very, very safe, well tolerated. The toxicity was basically that of the TURBT, saline and gem had similar toxicities. Next slide. And no very serious toxicities at all. So how did patients do? Well, if you had all the patients, including those with no tumors, muscle invading tumors, high-grade cancer, it was still a 1/3 relative reduction in tumor recurrence, an absolute 12%, similar to other intravesical therapies. If you only took those with low-grade disease, there was almost a 50% relative reduction in tumor recurrences and an absolute 20% reduction in tumor recurrences. This is very effective. Next slide. This was the intent to treat analysis, so you can see that it's clear these are cumulative incidence curves and gemcitabine prevented recurrences compared to saline. Next slide. This is the low-grade cohort where they're prevented and even more, the lines are separating. Next slide. If you had high-grade disease and got gem immediately after the TUR, because all the patients, both who got saline and gem, then received BCG, it didn't really prevent the recurrences. I mean, it was a little better, but not statistically significantly so. If you had low-grade disease, you still had a 3 to 4% chance over 4 years. Look at the saline arm. Look at those with low-grade or no cancer. It's 4 out of a little over 100 actually wound up having muscle invading disease subsequently. And it wasn't really meant to look at death, so there wasn't a significant difference in death. Next slide. The one study I had mentioned the first time around before it went dark for a while is this was studied by Boley, and he used gem. He found similar tolerance of the drug, it was safe to use, but he didn't find any improved efficacy compared to saline. One of the reasons was he only used a 30-minute or 35-minute dwell time, half of what we used in the study. And that's because gemcitabine has to get into cell, has to avoid deactivation, and has to be phosphorylated 3 times, and then compete with cytosine to get into DNA. Has to do all those things, and then one nucleotide is added, and then it will kill the cell. It takes a lot of time to do that. It takes an hour and 15 minutes to do that. He also had both arms getting continuous saline irrigation, which have been shown in at least one study to reduce the incidence of bladder cancer. So this is in both arms getting this treatment. And a quarter of the patients in his studies had immediate TURBTs, while only 5% in our study did, 5%. So more than 5 times as many had those, and those weren't considered failure of bad tumor in TURBT in his study. So it really was a very different treatment. Next slide. Next slide. Okay. There are other things we could do besides immediate post-TURBT, including enhanced cystoscopy. And particularly blue light cystoscopy has the strongest data. It gets stronger approval by the AUA guidelines in narrowband imaging, although they probably both work. But if you look at about the fourth line down, studies that have not blinded urologists to treatment, and the thing is, the what study that did, where the person who did the TURBT, the blue light, was not the one who did the follow-up cystoscopy. They didn't show it advanced. I still think that blue light works, but I mean, it's an intriguing thing. Immediate post-TURBT installation does work, but as few as 1%, that was a paper coming from us in the early 2000s, and probably it's closer to 30, 35%. Are the ones who get it. That means that 65 to 99% are not getting it when they should. Pazipone, which is a mitomycin analog, was recently not approved by the Oncology Drug Advisory Committee of the FDA. Mitomycin has had its own issues. Next slide. I only want you to look at the highlighted one because that's the only one that's relevant to this talk. And here, if you had low-risk disease, that included sometimes multiple tumors, but all low grade, that the recurrence with immediate mitomycin versus giving it delayed 2 to 3 weeks later made absolutely no difference. It's not terribly effective in this study. I don't want to go through the other ones because they're complicating. Next slide. And this is what I had mentioned before, that if you're going to give additional therapy besides the immediate post-intravesical installation, probably it's not going to make much of a difference. Here they used epirubicin, which is fairly successful in general, but then everyone got BCG afterwards in both arms, and so it didn't really make much of a difference. This isn't a surprise. Next slide. In terms of mitomycin, there have been drug shortages of mitomycin, around the first and second BCG shortage as well. There's clearly greater toxicity with mitomycin. You can look at the difference in cost. Mitomycin, for those of you who have run departments like me, this is a major issue, costs 18 times as much. Maybe less effective. They have never been tested head-on-head. It probably is, but that's not sure. Next slide. Next slide. I'm sorry, I'm talking loud. Okay. So the point is that, again, this is something that affects 45,000 patients a year. What if everyone got this? And so what would the cost be? And I won't go through this in huge detail, but next slide. So we do, to try to do a cost analysis, through the information from our study, we knew there was a 20% reduction. We knew how often the tumors recur. We knew that a small percentage of patients go on to develop muscle invading disease. We assumed all those would undergo cystectomy and they'd all be cured. Certainly something that's not totally true. We knew that a little less than 6% versus almost 9% had high-grade disease when it recurred. We assumed all those people would get BCG and then be cured again, never recur again. And we knew something about adverse events, and those with grade 3 adverse events needed some additional treatment. We assumed they'd go into the hospital. Next slide. We didn't know a lot of things. We didn't know the size of the index tumor. We didn't know the size of the recurrence, and each of these makes a difference because there's a cost involved. And the charges for a large TURBT are greater than for a small TURBT. So we didn't know that in the cost analysis. We didn't know how the patients were treated when they recurred, names of guesses, and we didn't know the number of subsequent recurrences or how they were treated. Next slide. We knew some costs, certainly the first two we just discussed. BCG is a lot cheaper. This was a year and a half ago. in Rochester, it's probably gone up, I'm not sure. That a drug installation in the office is you're paid a little bit, not very much, given that you have all the supplies. Cystoscopy at the office, this is how much you're paid, $58. Cytology, on the other hand, is $100 more than that. So that's something you can avoid with low-grade disease. Probably doesn't add much. This is a TURBT medium, and that's both facility fee and professional fee. Cystectomy, like 1 day in the hospital in Hotel Rochester, $1,500, and 1 day loss for work if you're just going to use minimum wage is $58 a day. So we had some costs, and we had to make a huge amount of assumptions. Next slide. So basically, if you look at the top line and the bottom line, use immediate post-TURBT gemcitabine versus no treatment, and then if the tumor recurred within a year, you get 6 installations of gemcitabine. It was about a 40% reduction in cost over 4 years for a patient who received gemcitabine. Even compared to mitomycin, it was about a 20% reduction in the cost getting in. That's, of course, the cost of the drug. Next slide. And if you look society-wise, the percentages are the same. But remember, bladder cancer is the most costly malignancy to treat over a lifetime of patients. The reason is exactly because of this, because of low-grade disease. You can reduce the cost by 40% by using immediate post-op gem. Next slide. The conservative estimate assumes equal efficacy. That may or may not be true. Clearly, there's more side effects with mitomycin. We can assume that. It assumes only 1 recurrence per patient, which is probably not the case often. It assumes only 1 day in the hospital for a grade 3 adverse event, and we had them lose 5 days of work. So you sort of figure that out. Next slide. But certainly, immediate post-operative installation therapy, particularly with gemcitabine, both reduces recurrence rates and saves society a lot of money and patients a lot of money, a lot of suffering. Next slide. These are the summation statistics from our study, but basically the number needed to treat in terms of patients is 1 in 5. Next slide. So I'm going to give credit to Jake Gans, who may be listening. And Alexis Steinmetz, who may be listening as well. We tried to see how often we were using this. Now that we had this information and had a study, and all my partners participated in this when we carried out the study. Next slide. And implementing scientific evidence into practice usually takes a long time, and it's something the NIH is very interested in. Next slide. I hate these diagrams. Much like an administrator, so I don't like them. But you really have to define where the gaps are. So next slide. So we did, and we just confirmed what someone had determined and shown in 2001, that 70 to 80% of the time, you know that's a low-grade tumor, without even knowing the history that they have prior low-grade disease. You know it's a low-grade tumor, so you know most of the time. Next slide. So you can't hear me on the audio?
I think you should say that.
Oh, okay.
Yeah.
Okay. So we looked and saw how we were doing. And Emmett Strong Memorial Island is another affiliated hospital. So we did a 4-month audit of this, and after my paper was published, so everyone should have known this, only 40% of the people at Highland were using it, and less than 10% of the time was it done in strong when it should have been done. A complete embarrassment. Next slide. Identifying stakeholders. And again, Dr. Gans did this, and I really credit him for that. He's a qualified resident now. He looked and he saw who's responsible. And clearly the one responsible is provider. That's us, attendings. But the residents help. And he sort of looked, Rochester has a strange system in which chemotherapy is made at the cancer center pharmacy, and they have to bring it to the OR pharmacy. I'm sure most places aren't quite that ridiculous, but we are, so you have to figure that out. And I think the major, and how do we get it? We had to get the nurses on board beforehand and during and afterwards. Next slide. And what are the barriers to doing all that ways? It's the nurses, maybe it's the pharmacists. No, it's us. It's us. We, people said I use it all the time. That's that brown line next to the bottom. That's what I said. It probably wasn't the truth. But it was really that people didn't know. They thought it was too dangerous because they were thinking of vitomycin. They were thinking of too many side effects. I didn't know about it. I didn't know it was available. That sort of thing. And so next slide. And so what Jake did was that he designed things. He figured out how this worked. Next slide. And he put up an order set so we could order the drug. And figured out how to get, with some help from me, I'm afraid, get residents to be able to order the drug too. It's the only chemotherapy it's strong that permits that residents to fit into order. And then he kept on pronouncing it, had a brand rounds, and then he kept on showing people what your scorecard is. Not embarrassed. Next slide. And so we went, if you look at on the right side, Highland Hospital doubled their use. We went up about strong, we went up 5 times, but actually what post-contraindication means is that these people either had too thin bladders or had too much bleeding where you couldn't clamp the catheter. We really went up from 9% to almost 80%, a 9-fold rise. And really, one person did this, which was impressive. I don't know if Jake is hearing me, but your ears are burning. Okay, next slide. So it proved that maybe we can do this for other things to get information science to work. Next slide. So how should these people be followed after you treat them, whether you use intravesical therapy or not? And I think, okay, go back, we'll hold it a second. Badar, you said something, but I couldn't read it quickly enough. Something about side effects.
I can read the question out loud. It says, intravesical Gemzar side effects reported in real practice seem to be higher than what was reported in the trial. What's your comment?
They aren't here, so I'm not sure if that's true. The one side effect that I know of that we didn't see at all, but 2 people, I believe, Kareem Sharmi, who's at UCLA, and Seth Werner, who was part of the study, although not during the study, and people who developed alopecia afterwards. So there must be at times systemic absorption, but we haven't seen it. I haven't personally seen it. I probably have used this more than anyone else, and I haven't seen it. We haven't had a lot of problems. So it's generally safe. It's not totally innocuous, and if you have a very thin bladder, it's probably not good to use, but it's generally safe. How do you follow patients? Low-risk disease. I do what the AUA does. Cysto at 3 months, cysto 6 to 9 months after that, and annually for 5 years. But what I don't do, which the AUA recommends, is stop then, and I actually continue it annually after that, once the patient agrees to that. That's because I personally have, it's really anecdotal, but I've seen recurrences 10 and 15 years out of bad cancer after. Remember, in 4 years, 4% of these can become muscle invading. probably much higher. So I do it forever. I don't know if that's right. I don't get cytology. Have low-grade histology and high intermediate risk. And I still follow the guidelines, which is every 3 months for the first 2 years, for 6 months for the next 2 years, and then annually thereafter, forever. I do get cytology for many intermediate risk patients, certainly not all. But I must admit that if you're the low intermediate risk, you had 2 tumors the first time around, but very small, that's still considered low intermediate risk. I'm not sure I follow them this way. I follow pretty much by the book because that's what I'd like to say. Next slide. And finally, who should have a repeat TURBT? A question comes up all the time. We look at the bottom, those who have high risk disease, high grade T1s, very large high grade TAs. Even if there's muscle in the specimen, I usually will do TURBT. Small high grade TAs, I won't. And that's because there's a 10 to 20% chance, even with muscle in the specimen, if you do a repeat TURBT, actually muscle. And if there's no muscle in the specimen, that's up to 35, 40%. How about people who have low risk disease or low intermediate risk disease? It's basically people in your heart you did an incomplete TURBT, or you could have, you don't know you did, but you're not sure. People with very, very large tumors, where you could have missed something, with an enormous number of tumors, where you missed something. Tumors around diverticuli, where you chicken to get it all out. Tumors right in your orifices, we're concerned about getting them out. Tumors in big patients. I don't know how many of you at other institutions, we have it here, have an ultra long resectoscope, but for probably 2 to 3% of men undergoing TURBT, you need something like that. These are basically kind of thick men, often tall as well, but mostly thick men. They get up to the upper edges of the resectoscope will help, and that other situations where you didn't get it all out, you don't think. So that's going to end my talk. How about answering questions? Can you hear me?
I can hear you great. I'll wait for questions to show up in the chat, and I can read them out loud to you, and then you can go ahead and answer. Just as a reminder, please, everyone, type your questions in the chat and avoid coming on audio just to avoid cross-contamination if you can help that. So just waiting. Thank you, Dr. Messing, very much for the talk. Even with,
apologize for whatever the...
no need to apologize, even with the technical delay. It was a great talk, very informative. We'll just wait for any questions. And as we wait for people to type in their questions, there have been some questions on the side about video recordings. We're working on a way to distribute that to everyone in an open source manner. Right now, all the recent lectures have been recorded and saved, and they'll be sent out as soon as we can do that safely to everyone.
Do you have each of our slides?
In most cases, the presenters have forwarded their slides, but ultimately we'll make some kind of sharing program to have all the slides and all the videos, hopefully in an easy to share way. But we're just waiting a little bit from our administrative approval. So I see a question here in the chat from Dr. Joseph saying, any effort in pushing this similar manner at other institutions giving BCG shortage?
So I'm going to try to understand what you're saying, Sean. For high-risk disease, GEM is probably as good as mitomycin, but it isn't as good as BCG. So if you can give BCG, probably with even some form of maintenance, even if it's much lower dose maintenance, you should try to do that. If you can't, then the option is, I'm sorry?
In terms of your local success, I guess expert opinion, sounds like you're favoring BCG if available.
For high-risk disease, for sure. For low-risk disease, no, I think, but I don't use BCG for low-risk disease, or intermediate-risk disease. So I only use it for high-risk disease. But I think that if you could try GEM, you should use maintenance GEM if it works, meaning that after the first 6 installations, it helps. But I mean, you know, when BCG was compared to anything else, it was better, especially if you use maintenance BCG. So if you can get it, you should do it. I don't know if that exactly answered Sean's question, but.
Next question we have is that.
By the way, I don't know how many of you are in SWOG, but if you are in SWOG, there is a study where you can get the BCG, shortage or no shortage, called PRIME. So everyone who's at a SWOG institution should clearly, for the first time around, get BCG for high-risk disease. Okay, sorry I didn't answer for you.
No problem. The next question we have is that you mentioned that a thin bladder is a contraindication to intravesical Gemzar. Have you seen any major complications post-installation?
No, I have not, and we didn't have it in the study, but that's because people chicken out from giving it to it with ultra-thin bladder. So when we did very deep resection, let alone one where you thought a perforation, people don't give it. Remember, 15 to 25% of the time after a TURBT, you shouldn't be using this. It's 15% in our study. But you shouldn't be using this because you can't clamp the catheter and you can't, the bladder's too thin. So,
Perfect.
you know, if you look hard enough, you can cause a problem. I haven't seen it, but I certainly have seen it with mitomycin.
And a great follow-up question to that from Dr. Kogan. In the absence of bladder perforation, is there any patients who shouldn't have intravesical chemotherapy, such as those with very low-risk disease?
Well, very low risk probably should have it. They do very well. And there was a recent paper that tried to distinguish low risk from very low risk, but even the tiny tumor should have it because they still recur. So the real issue is who should get it. If you were thinking about it and you knew for sure, or pretty much knew you were going to give additional, a course of 6 weeks intravesical treatment, whether it was chemotherapy or BCG, the evidence to say that immediate post-TURBT intravesical therapy helps in that scenario is pretty small. I presented the thing about epirubicin, which is a good agent, and it didn't make any difference if you're going to give 6 weeks of BCG right away after. I think the same is true. So if you have a high-risk patient, you don't hurt them, but you don't help them by giving immediate post-TURBT intravesical. And you remotely run the risk of doing some mischief.
We have a question. How should we handle equivocal gross appearance of possible low-risk bladder cancer versus nondescript pathology? Should we hold off on intravesical chemo post-op until we have a pathological diagnosis?
Well, I mean, I think a couple of things that I talked about would address that issue. The article by Boscheider, in which he gave mitomycin immediately after the TUR, or gave it 2 or 3 weeks later, when there was no difference, but there was no particular benefit in that. So I think if you're going to give single installation therapy, give it, you know, within 24 hours of when you've done the resection, or you don't bother giving that. Now, what was the other question? What was the other part of that?
I have a question from Artelon that says, who would be the best candidate for mitomycin or Gemzar for low-grade solitary small tumor, multiple small tumors?
No, they could be multiple. I mean, in our study, a third of the patients were multiple. So low grade, tumors that you think are low grade, that you think they're not deeply invasive, and that, but they don't have to be pure low risk. They don't have to be solitary. And that they're not so big when you did your TUR that you're going to cause a hole in the bladder when you're safe to clamp the catheter, but they should be patients with low grade tumors.
Dr. Messing, you're very popular. We'd like to thank you very much for your time and very thorough literature-based review. Had some great questions. Any pressing issues, we encourage you to reach out to Dr. Messing, but thank you all. We really appreciate your patience.
Thank you all again. I'm too computer uninformed to take any responsibility for this thing going off the air, but I'm sorry it happened. I appreciate anyone who stayed on and were kind enough to stay on until the bitter end and ask questions. So thank you all very much.
Thank you.